Go ahead and get started with this through. All right. Today is July 20th, 2021. It's 9:04, I think, according to my clock, 9:03. I'd like to call to order the Incarceration Prevention Reduction Task Force Behavioral Health Subcommittee. As we begin, I'll go ahead and read our land acknowledgement statement. Before we begin, we acknowledge that we are gathered on the traditional and unceded territory of the Lummi, Nooksack, Samish, and Semiahmoo people who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us together here today. And please join us in uncovering such truths at any and all public events. All right, just for the record, welcome Marlene. We don't yet have a quorum, but we'll go ahead and kick off. Dan, did we want to still start then with committee priorities?
Yeah, I think so. Let's just stick to the agenda. We'll just go through it.
Okay. Jill, if you wouldn't mind thank you. Okay, so just by way of reminding us all, these are kind of the ranked order. And Jill, I want to give you a shout out and thank you for administering that survey and compiling our results. This group has done a lot of work and a lot of brainstorming and talking about different behavioral health issues and how those affect individuals that are in our criminal justice system. We wanted to get kind of a take though, because there's so many things. We wanted to be able to help this committee focus so we could maybe move the needle on a couple of these issues. So we'll go through a couple of these. I believe last time, if I remember correctly, and Jill and Dan and anybody else chime in, I think we kind of covered the service capacity and staff. And we actually spent a decent amount of time talking about how that affects both like a non-profit or behavioral health agency, but also law enforcement. Law enforcement is also hiring trained individuals, police officers, behavioral health officers. So we really look at staff in a very broad sense and seeing those issues. Later in the agenda, you'll see that the group that got together to talk about funding recommendations to the county council with some of this COVID relief funds, one of the things that we really targeted and we put as number one, and Arlene, you can chime in if you want, but we really put in recommendations regarding behavioral health staffing. What we are hearing from many agencies, including Compass that has contracts in the jail, who's looking for over 100 positions to fill. This is a big issue. And if we want to have treatment options outside of the jail, well, we need to have the clinicians to do so. So it is a pain felt by numerous organizations and law enforcement and criminal justice system in Whatcom County, a staffing shortage. So we do believe that ARPA funds could be helpful in terms of recruiting, retaining, maybe moving bonuses, signing bonuses. We're going to let people smarter than us make those calls, but we want to make that recommendation. We'll talk a little bit about that later. The second item we also did touch, so just by way of summary, racial equity, applying a GARE overlay to everything we do. The only update that I have for you on that, I mean, obviously the fact that we're bringing up, it's showing that we're using it. I did reach out and the steering committee had a discussion and would like more information from GARE about some real practical, tactical ways that we think that this could be helpful for us. And we're talking about evaluating the option of membership. I reached out to the GARE director who responded, and I think they'll be joining our steering committee. So that will give the chairs of the task force and sponsor, Council Member Buchanan, some good information to be able to decide, does this make sense for Whatcom County or not? And how might it help us? We get into the next couple, and these are new. So we haven't yet discussed these yet as a committee. But you can see the next ranked issues, juvenile SUD treatment and services and crisis response. And Dan, I think if you wouldn't mind, I might have you just kind of recap a little bit about what you're familiar with our alternate response team, kind of a status on that, And then juvenile SUD, I saw Byron just hopped on. Obviously, as you're aware, some group of us were talking outside of behavioral health subcommittee. Might there be an opportunity to have some targeted programs for pregnant and parenting women, and also possible juvenile SUD? Apparently that's a big issue. I'm going to open up the one on juvenile SUD first. I'm not overly familiar with this. I mean, I am with pregnant and parenting women because Byron led that through us. I want to get some feedback from members about this. If somebody marked this as really critical, tell us kind of what you're thinking. Do you have any proposals? What might we do with this as a behavioral health subcommittee?
I know that was one of the things that I highlighted as a priority, and I think that goes along with a little farther down some of the prevention that goes with youth. And I know in another meeting we were talking about what would happen with the old triage center now that the crisis stabilization center is open. You know, my ask would be I'd like to see that kind of replicated, but focusing on youth, because I think a lot of these programs that are focused on substance use disorder and mental health seem to focus on adults, a lot of time older adults. And I think the youth kind of get not necessarily forgotten, but they're kind of an afterthought. But I think we are seeing more youth, adolescents that are getting involved in drugs. Obviously marijuana is very prevalent, but we're talking opioids, heroin, things like that. And so that's obviously a disturbing trend. And then I think along with that goes an increase in mental health calls related to young adults. So that would be, you know, if we don't do something about it now, we're going to continue to deal with that problem as they're adults.
Arlene?
Over the years, I've had many stories told to me from families that have tried to get care for their children or their teenagers. And they have said that there was nothing available for them, that they went from the ER to the police department, back and forth over and over again, and they were enormously frustrated. So it's true that we don't have sufficient services for young people, but not for old people either, not for the elderly. And that is also a missing piece. But what I've been talking about that we might do, I think we ought to do really, would be to have a large counseling center to address any age of person and be available for people, somewhat like a behavioral health ER. And that way we don't have to divide it up into different age categories, but that we can address all mental health and drug addiction needs entirely.
Thanks for that, Arlene. I know you articulated that a little bit with some of our recommendations, funding recommendations to the county council. Dan?
So I'm trying to get a lay of the land here on SUD for juveniles, and the Blake decision does not apply to minors as far as I understand. And so there could be some leverage there to incent treatment options. And I'm trying to get a handle on converting the old facility over on Division Street into something that could be used for juveniles. I'm not opposed, Arlene, to having it be, you know, something that would treat older people as well. But I really, you know, this committee has been really good in terms of looking upstream and trying to figure out how do we kind of turn the spigot off, so to speak, when it comes to people when they're 18 and older entering into the jail system or criminal justice system. And so I'm really curious, Undersheriff, just to understand your perspective on how that conversion might happen, and if you have a vision around that. I'm pretty intrigued by prevention services for especially teenagers who are experimenting and getting into problems and perpetuating the cycle potentially.
I don't have any objection to doing what you're saying. It's just that I'm looking at the problems that we're facing from a larger perspective, and that's one of the most important things that we have to do, is to be able to receive the people who are going to be not addressed by law enforcement. And those people need to have services immediately. And if, if we don't have what is needed, how are we going to do this transition from law enforcement to behavioral health services instead? We've got to have a place for people to come. We do not have that. Crisis stabilization does not address that. And this is the larger part of our population.
Right. I'm trying to stick with the priorities that the committee came back with, and item G is specific to juvenile SUD.
Oh, okay. Yeah, you're right. Sorry about that.
No, it's fine. No, we have a lot of problems here to fix.
Yeah, so no, I mean, I have no objection to that issue. I absolutely know it's important. It's important for prevention. But I guess what I'm saying is that our need is something larger. And it doesn't make any difference to me where it's located. It's just I'm familiar with that building because I worked in it for 10 years. And I know, what its capacity is. And also that's a very large property. That property has still quite a bit of space.
Arlene, thanks for your feedback on that. If we could, Undersheriff Chadwick, if you'd like to respond, and then I believe Byron was ready to speak as well after that.
Sure. And again, as far as the old triage center that it was originally designed to deal with both behavioral health. People could go there more as a detox center, and as Arlene said, it has limited capacity, but as a place that's specific for youth, I think it could be very similar to what's happening across the way at the Crisis Stabilization Center, where you have both, half of the building is for mental health and the other half is for substance use disorder. But I know it's been a frustration from law enforcement when we try and divert young people. There's just no resources. And I know Jamie Collins, who was our original behavioral health deputy, that was one of the things he really wanted to focus on, was trying to find additional resources for youth. And I know that now he's retired and he's moved into working with the school districts and still making that a priority. So I think, obviously there's more and more resources geared towards adults, but whether it's mental health, substance use disorder, or homelessness, it's really not appropriate to put young adults in the same location with adults, and they're just not comfortable doing that. So I asked Ann Deacon if it was even appropriate to have a facility like that in such close proximity to the crisis stabilization unit. But that was one of my thoughts is, that's not necessarily turnkey, but it's already designed for that. It would just be a matter of bringing in the staff and making it known that that was specifically for youth in the area. But that's like I said, over the last couple of years, as we've gone through these different committees related to behavioral health, there is a glaring need for the youth in our community that struggle with the same issues that a lot of the rest of the population does.
Byron?
Thanks. Yeah, I think it certainly is a big issue. I kind of wonder, I hear kind of this, there's not enough services, or there's not a service available. I'm not quite sure what service that you're really has been effective in treating youth with these programs. So I'd really want to, before saying, create a location, it's like, what kind of service is actually effective? I know, substance use disorder, it's one youth have to come and want to get help, otherwise they're not going to get it, so what's the incentive for youth just because there's a facility there to go to that? I wonder where the motivations are for them to get help especially at that late stage of already into, having a substance use disorder at that age. Oftentimes it's really hard to get them to, realize that treatment is needed. Without carrots don't work. It doesn't seem to me. So if the only, motivation to get somebody, so I guess it'd be great to see a model that actually works, where actually youth actually are engaged in that particular program, not just on a small scale or just on 1 out of every 10 or 1 out of every 20. But what is the service that we're talking about before kind of creating a space for the service to be provided?
Dan?
I'm wondering, this scored pretty high. It's only 9 points below the top scoring priority item. I'm wondering if we can put a pin in this one and try to see if there's other models from different communities that we could at least look into and try to get a handle on this. I agree that, we know that juvenile neurological development, that frontal cortex doesn't close until about age 24. And if you are 25, and if you are, have a substance use disorder involved, it might not happen until later. So we know that the impulsivity, decision making, all that stuff is affected. It's different in youth and young adults. So I'm wondering if we can try to maybe I don't want to table necessarily this item, but I do want to. I don't know enough about it to render a good decision. I think that there's some pieces on the table. The former center on division, the triage center could be a location, but I think Byron's right. Until we have the program and some models to look at, we'd have to have. There are multiple components to it, obviously, and then I would want to understand the legal ramifications. I think Blake does not come into play here for that Supreme Court decision, but I'm not completely sure. I'm a little uncertain as to how 1310, House Bill 1310, sorry, and 5467 come into play when it comes to going hands-on on people who are, to taken into custody and such. So I don't have those pieces. I'd want to know those items, have clarity.
Thanks, Co-Chair Hamel. And I think you're right. I'm kind of thinking that maybe we could hear from Chris really quick, who I think was about to unmute. And
Is
then
he on the call now?
Yeah, Chris has joined on the call now.
Right.
Hear from him a little bit, and then maybe what we could do is plan to get maybe a presentation by a provider who could kind of illustrate some of both the assets, what's currently available in the community, how that's maybe short or maybe not functioning, and maybe could help kind of frame this conversation up. Chris, did you have something that you wanted to add? I thought I saw you unmuting there.
Yeah, I agree, Dan, that it makes a lot of sense to try and find models that are already working other places. I know that Washington State has some momentum going in the direction of a youth and family focused crisis outreach program that's similar to MCOT, but has some really specific elements to serve youth and families. And so that's already in the works from my understanding in Washington State in terms of funding. I don't know if that will come through some element of HCA or North Sound Behavioral Health, but and we looked at some models in other places that were doing that and had some really interesting pieces that were taking the strengths of MCOT type of program and then adding some elements for youth and families where it helps the parents and the family be more involved in that process. One of the pieces that I thought was most interesting was an 8-week follow-up after the initial response. So let's say you have a crisis event on a Saturday night. And then, like, for example, I walk through this with a lot of parents and families in our district. It tends to be fentanyl, other things like that. You'll have something will come up. Parents will realize as their kid is using. And there's always that grief process for families to go through if they haven't been aware of it, to realize the extent of the need. And so usually there's a light, a really strong desire to not necessarily minimize, but want to say, okay, we can do this. We can kind of do this in-house. We're just going to do outpatient. And then over those weeks, if there was a 6 to 8 week follow-up, like 3 steps where you have the initial response, that 6 to 8 week part, which is more of a bridge to ongoing services, and then the treatment is the 3rd phase. Whether that's intensive outpatient, outpatient, or inpatient, I've noticed that when parents are able to be involved, they have much better long-term view, obviously. And so they're able to be that additional guiding. Like sometimes kids are, you have a 16-year-old who's ready to get treatment and they're ready to get help. And that's great too. But other times that 1, 2, 3 stages is really helpful, because most parents I talk with are not ready to send their kiddo to inpatient somewhere else right away, because they're still grappling with the severity of the situation. But having somebody walk through that with them and mitigate between safety of their child and also coming to terms with what's actually needed for long-term success takes a couple weeks. And so I think CCS right now, I've had good experience having kids go to CCS for evals up on Lakeway there, and then use that as kind of a door to inpatient or whatever the next level of treatment is needed. If that was able to stay as a system we already have, and do something like this youth and family crisis system where we have a SUDP piece of it and a mental health piece, I think that could be really successful. That 6 to 8 week follow-up seems like the biggest thing. It allows parents to be involved, families, and it also gives families time to really realize, okay, here's the severity of the need, and I know my child best, and how can we navigate that to get that kid so they're not just bouncing back and forth between outpatient. So anyhow, that's all I wanted to share. I do think obviously every state has their own age of consent. Ours is young at 13, and there's a lot of benefits to that. And there's also a lot of times when that really ties families' hands in terms of trying to help their kids get services that the child may not be interested right away. So obviously we're probably not going to change that right away, but that's I think this type of program, being cognizant of what dynamics that age of consent brings up, we could still help parents and families be involved. That's what I wanted to add. Thank you.
Oh, that's really powerful. And I think that's a good reminder to us too. I think a lot of times we think adolescent, my brain went to 16 and 17, but in this state, you're right, at the age of 13, you can get mental health treatment and not share it with your parents if you so choose, and you have the right to do so. So if you're looking for parental support and the kid shuts him out, that could happen. That's a real challenge. Chris, I'm hearing about this potential MCOT. This could be a way to kind of, as Dan said, we want to put a pin in this and get a little bit more information, maybe even get a speaker to join us. I was also thinking, I don't know if CMAR Visions is still in operation. It used to be an inpatient option for youth. So obviously they would have to qualify on the ASAM level that they needed inpatient. Does anybody know, is CMAR Vision still a going concern? Or
Yeah, they still are operating now. In fact, we serve them as a district for their academic needs, and I work with them some, and I used to work there about 20 years ago. But yeah, they're still operating, usually because that's a level 2 facility, so it's like 60 to 180 days. When you get to that level, usually we try and send clients or patients far away, so they'd go to Daybreak and Spokane from here. Or now I know there's some pieces of that don't make sense when you're trying to involve the family and keep everyone, how do we support them when they get out? But I think there's also some wisdom in them not just being able to, leave and go 1 mile back to their friends or something. So I know that's traditionally been, if somebody lives in Vancouver, Washington, they'll probably go to Visions. If they live in Bellingham, they'll probably go to Daybreak in Vancouver or Spokane. They send people different places, but it's still around, and there's, I think, at least 2 to 4 level 2s and probably 5 or 6 level 1s that are like that 28-day kind of place in the state.
thanks for that. I think what I'll offer, if this sounds okay, I'd like to affect what Co-Chair Hamill brought up as putting a pin in this, but an offer to do a little research with the health department staff. You know, we're unfortunately we couldn't have Perry Maury with us today or Jackie Mitchell, but I'd like to consult with them in terms of teeing up a possible presentation, and we can go into this a little bit more fully. I think we've framed it up. There's both treatment needs. There's needs. For law enforcement to be able to have a place for people to go and to know where to send somebody when they run into that kind of a situation. So that mobile crisis could be a good addition for that. And then also just to some, Under Sheriff Chadwick brought up the notion that maybe this could be a purpose for the old crisis respite. So with that, if that's all right, we'll go ahead and move on. I think we've got just a little bit more time, Co-Chair Hamill, if you agree to get into our next one, which is crisis response. And the way I read this, and I'm guessing from our committee members that rank this, by the way, tie, right? So these things are so close to like really being the top. That this would be labeled as kind of an alternate response team. And if you would, Dan, would you tee us off with at least kind of, you gave a really good lay of the land yesterday and at other times about what you're aware of, at least in Bellingham, and then maybe Under Sheriff Chadwick could help us a little bit understanding and framing this from the county perspective.
Sure. So it's important to remember that item H here on our list is tied in with item O, which is the #1 scoring item, service capacity. And Jill, can we take on the list here, the agenda, just so we can see each other a little bit better, just for a minute here? Okay, a little bit better. All right. Okay, so what we're talking about is the ART, the alternate response team. This is a Bellingham only model at this point, but I want to make sure that I acknowledge the county's help, in particular the sheriff's office, county health department, and EMS for just bringing their full capacity to help try to initiate this ART, alternate response team. This team would be composed of 1 behavioral health specialist and 1 EMTB, which is like a basic firefighter. 2 teams out covering 7 days a week, not quite 24/7. The idea is that these teams could respond to about 4% of 911 calls. In Bellingham, equates to about 33 calls per day for certain types of behavioral health calls, non-violent. This could be a person experiencing a crisis. They're perhaps yelling or whatever the case may be, but there's not a crime being committed. That ART was first developed in this committee in March of last year. And then we all know what happened in March, later in March of last year, the global pandemic happened. And so it really got put on hold for a bit. But later last year and early this year, we had other communities, behavioral health response teams come and present to City Council. I believe we had Portland, Denver STAR program, Albuquerque. They were just getting up and running, so we could learn a little bit more about how those programs worked. After those presentations, the aforementioned groups, sheriffs, EMS, health department, I was in on the call, met weekly to analyze call data to try to understand where we could send these teams. We didn't want to send them into any kind of dangerous situation, but we did want to try to alleviate some of the 911 call volume. Since that time, House Bill 1310 passed, and it's just we have issues now that we're not gonna have a police response to these types of behavioral health calls. The initial pilot of the ART had visioned an officer riding along with the teams to just make sure things were okay. And then the idea that we could expand the call type from about 4% to maybe 10 or 11%, so we could just respond better and have better patient outcomes. No, that's out the window now. That's not going to happen. Police are not going to respond to behavioral health calls in that way. The 1310 really put restrictions on responses. So we are left with the ART being the only response possible for certain types of behavioral health calls. Now, That being said, we are far from being established with the ART. That goes to item O on that list that you just saw, which is service capacity. We simply do not have a pool of behavioral health specialists that we can draw upon to staff this program. This is not a Bellingham or a Whatcom County problem or a Washington State problem. This is a nationwide problem. Behavioral health specialists are not paid the same as EMTs. They're paid at a rate of probably 60% or 70% of what an EMT would make. The work is every day is a crisis. Every day is the unknown. It takes a certain type of person to want to do this type of work and to be good at it. And so that's really the issue. That's the animating issue. That's the big one. The other one is that the acquisition of the specialized rigs that we would need to help our workers and keep them safe and provide for the patients are months, if not a year or more out in terms of getting acquired. For example, about 2 years ago, I signed off and supported the purchase of 2 community paramedic rigs. 18 months later, they have yet to materialize. They're lost in the supply chain. I don't know if it's the chip problem or what it is, if it's COVID related or what, but the long and the short of it is that ART is, I don't know, 6 months to maybe a year from being implemented. And that's after all the work that we put into it. We've been working on this for quite some time. A lot of people have been working on it. And it's very frustrating that the legislature came out with these laws that are basically tying the hands of law enforcement and also creating problems on how first responders respond. So that's my, I wish I had a better, report that I could give you all, but that's really the issue the issues as I see it.
Thanks, Arlene.
What does a specialized rig consist of?
Be able to transport to a crisis stabilization center, to whatever ED. It's a rig that probably needs a wheelchair access to it, ADA accessible. It's got to have all the gear, the medical equipment, oxygen, whatever the responders need. At this point, I'm ready to break into the surplus yard over at Public Works and just grab one of our whatever we have over there and just use that. But I don't think they'll let me do that. I don't want to get arrested.
Well, that would certainly make for some interesting headlines, Councilman Hamel. Under Sheriff Chadwick, I wonder if you wouldn't mind just updating the group. We're aware of some existing resources that the county has had in play for a long time, behavioral health teams, pairing with Grace, and any other things that you might have about the sheriff's office attempts and wins so far on alternate response.
Sure. Like I said, we've had the behavioral health deputies for several years now. We have 2, obviously because of staffing shortages and whatnot, we had to reduce that, but we will have our second behavioral health deputy back out there hopefully in September. So we have a person selected, and once staffing, we get through the busy summer, we'll have that deputy. So those 2 deputies are primarily will respond to mental health calls. They don't have anybody riding with them, which is, I know they have some clinicians that are working in Bellingham that ride with Bellingham PD on a fairly regular basis. We would like to see that program expand to the county, and I know the health department may have some funding, and they've talked about maybe having somebody ride along with law enforcement. But as Dan said, because of some of the changes in this last legislative session, there's been some restrictions on law enforcement, and when we can use force to take somebody into protective custody, which is historically, not everybody wants to go for an involuntary, and sometimes that requires a certain level of force to protect them and others and get them to the services that they desperately need. So, we'll continue to work with that. It doesn't mean necessarily that law enforcement can't go to those calls, but the legislation is very clear that if there's not a crime or there's not an imminent threat to the persons involved, then one of the alternatives that we're supposed to exercise as part of de-escalation is to leave the scene. And again, if we're leaving, mental health professionals, firefighters, EMTs, people are there that are also trying to help, that have responded. That causes some concerns for us. And I know I've had a lot of meetings, as you can imagine, since May with various fire districts, fire departments, mental health providers who, share that concern about going to these type of calls by themselves. And certainly we don't disagree. There's just, some calls that really don't require a law enforcement response. And, while we're, all our deputies have crisis intervention training, we're not mental health professionals, but as first responders, we go there, we render the scene safe, and then we try and triage, decide what services are best suited for the situation, and then call those in. If we had a mental health professional riding with us, obviously they could take over and we could step back. Doesn't necessarily mean we have to leave the scene, as long as we're there to try and make sure that they're safe. But there are going to be calls that we're not going to go to, just based on the nature of what's dispatched. And we've talked about the challenges that come with dispatching a alternative response versus a law enforcement response. All that is predicated on the information that's being provided to the dispatcher, and that isn't always accurate. I can tell you over my career what I'm dispatched to and what I end up with once I get on scene are two completely different things, and these things are rapidly evolving. So I know obviously VOA families have the option to call that. That's not necessarily an immediate response, but those are the MCOT, the follow-up resources that come out, and that's right now what we're using. If our mental health deputies need somebody, they'll either call MCOT or they'll liaison with the GRACE program and other resources that are available, and try and get them either to come out to the scene or do some type of follow-up if it's not emergent.
It strikes me as I hear about some of the things that are available in Bellingham, as you mentioned, Under Sheriff Chadwick, that in Bellingham they might be able to have a behavioral health professional ride along in that vehicle, and in a rural areas of Whatcom County we don't. And it just strikes me that there's a little bit of an equity issue here with services, and so hopefully we can address that issue, and that your deputies can have access to some of those same things. And I would argue that for the people you all are serving, being able to do that in one shot and not have to wait for somebody else to arrive. And I've done just a bit of research on alternative response teams, and even in cahoots, right? The police are often the ones calling cahoots in. So they go to the scene first, as Under Sheriff Chadwick mentioned, and then they bring them in. But having that even in the same vehicle, I think is really the best outcome, because then you've got time on your side. You're dealing with it quickly, you're dealing with it immediately, and people can get help that they need after the scene has been determined as safe. Thank you for the updates. Arlene, did you want to add something in there?
No, I asked the question. Yeah.
Okay, all right. So obviously this, and Dan, Councilmember Hamel, has tied this together with our with challenges. I'm pleased to hear that we're going to have a deputy back on again. It sounds like there's going to be ongoing issues about what engagement looks like at each of those calls. And if you wouldn't mind, Under Sheriff Chadwick, Dan talked a little bit about percentage of calls. Do you think that those kind of numbers that he was throwing out, I think that they did a lot of work parsing out those 911 calls and looking at those 4%, and it looks like maybe upper limits of 11%. Does that sound at all similar, or is that just not data that we have about county calls?
I don't know what the actual data is. Certainly there's a number of welfare type calls and things like that hopefully the dispatchers can get sufficient information to make a determination that this really doesn't require a law enforcement response. It doesn't involve criminal activity. There's no immediate threat. We just need somebody with behavioral health expertise to come and assist. But I think obviously a large percentage of our calls have a mental health or substance use disorder component. So it's of those calls, what can be parceled out to an alternative response, and how is that determined? So that will be the challenge for the dispatchers, at least.
Co-Chair Hamel, is there anything else we wanted to hit on this particular issue? I know that we're close on to 9:45. We may have some other folks joining the call.
Just two other items. One is that the ART alternate response team was modeled roughly after MCOT. MCOT was the closest type of model that we could use. And MCOT's response is not immediate, but we wanted the ART to be immediate, obviously. And then the other piece is that funding, I don't think funding is going to be an issue. I've met twice now with department heads, fire chief, police chief, mayor, finance directors, and such. And this doesn't seem to be an issue. I wanted to use ARPA funding to fund the first year, be $838,000. Finance is coming back and saying, you know, look, sales tax has come back strong post-COVID. It didn't, when we're creating a new program, we create what finance refers to as a bow wave. So you picture a boat in the water and you create a bow wave that kind of goes on forever. That's the same thing with a program like this. It's in perpetuity. So it means that using one-time dollars might not be the best way to think about it, and to go after general fund dollars post first year. We're talking probably $500,000 for 7 day a week, not quite 24/7. I don't think we need to, I don't know that we need 24/7 on this, but that's yet to be determined. So those are the two pieces I'd add in there.
All right, anything on this particular topic? Jill, would you go ahead and put our list up again in our agenda, if you wouldn't mind? All right, thank you. I don't know that we have a time to go into the next particular one. I'm curious from Co-Chair Hamel on a next step for this committee regarding response. I think for we're going to talk a little bit in the funding priorities about the staffing shortage and kind of a recommendation. So I think we've got kind of something for that juvenile SUD. We want to bring in some expertise so we can educate ourselves a little bit and possibly noodle on that. Councilmember Hammer, what might be a good takeaway from today's meeting on alternate response, and what might we tee up for the next time?
It's a good question. I think that, I just wanted to make sure that this committee understood the challenges for alternate response.
Mm-hmm.
And that it's not going to be an immediate solution, and that the legislation coming out of Olympia created problems that have hindered the ability to deploy that resource for our community members. Unfortunately, you can talk about unintended consequences. This is one of them. I would say that we need to continue the discussion on ART in this committee, because it's all behavioral health. That's what this program is about. I'd like to come back. I would like to see if one or two of us could take a look at other programs on juvenile SUD in other communities, and just kind of do a basic search and come back at maybe our September or October meeting, because it did score so high. And the history of this committee has been to look upstream, and I don't want to abandon those efforts because we're in this kind of more crisis situation with the House bills that have come through. So I think that we need to do those things concurrently. Focus on the upstream. We've identified juvenile SUD as an issue, so I'd like to focus in on it and see if there's any volunteers that could just do a little bit of research, and if it's appropriate, invite the program's director from a different community to come and present to us at a later date later this year in probably the fourth quarter.
All right, that sounds like an excellent plan. So committee members, we'll do some of that research. I'll start with reading out to the health department. They're always a great place to start with Jackie and Perry and kind of get us the lay of the land. And we'll tee up some stuff for that one. And thank you, Councilmember Hamel. With that, obviously we've got more priorities on that list. And just to remind ourselves, our intention is not to go through the entire thing, everything, but spend a little bit of time digging in to each of those, figuring out what might be items for us to continue and to pursue. So we're going to keep bringing this as your co-chairs. We're going to bring this to you every time, and we'll hit other topic levels. So we've gone through kind of the first four and in a little bit of a depth. We're going to continue to go, especially into a couple more. But I think before we go too far down on the list, as Councilmember Hamel stated, we want to go into a little bit more depth that we weren't able to do with juvenile SUD. So thanks for your ranking and for the participation, Jill, for administering the survey. It gave us a really good idea of what's the most important so we can focus. I'd like to turn your attention now. We're going to move on to funding sources. And I think everybody was here, but Deputy Executive Tyler Schroeder made a presentation to the committee of the whole and talked about ARPA funding. And why this can be so important for behavioral health is, well, you can use the funds for behavioral health initiatives in response to COVID, things pursuant to COVID, things that we had to leave behind and we couldn't fund because of COVID. Those types of issues. And there was kind of an inherent charge in his covering that, make recommendations on what you all think would be the most important. So if you remember the last meeting, we did talk about that a little bit, and a small group of us from the behavioral subcommittee met. We were under the quorum requirements, but we had a great discussion, and Heather Flaherty from the Checkout Out Health Foundation agreed to convene us. We met two separate times, one last week and then just one yesterday. That group was Heather, myself, Arlene, and Michael Smith, and Chris Cochran joined for a bit as well to talk about, well, what would the recommendations be for funding? Obviously, as we just heard from Councilmember Hamel, ARPA funds are one time, they're not ongoing. So where could we get the biggest hit for the things that this committee feels are important? That's going to reduce incarceration. That's really our key charge, right? So our group was able to have a discussion around that. And I know it was sent out late, but we tried to do an output of that. So Heather volunteered, did an outstanding job kind of summing up that group. And Jill, would you mind showing that document for our group?
Sure, just give me one moment.
I am hoping that that Heather could join, because this is a lot of her words in here. But like I said, she did a great job bringing it up. So if you would, this is kind of the framing, but I'll highlight to you guys 1 through 4. So these are the 4 issues. And what we did is the list that we were just going on, those funding priorities, and Arlene, please chime in at any point. We kind of took those, and from our list, we said, well, what makes the most sense? We weren't sure that lifting up juvenile SUD when we didn't know a project made sense, but behavioral health workforce was #1 on the list. As we talk about anything from an alternative response team to staffing in the sheriff's department to a clinician at Compass, we know that across the board, it's a huge issue. ARPA funds could be something for that. Pre-trial and reentry support was another big issue. We're seeing a whole lot of issues with folks transitioning. Although the jails there are less people in the jails, there's also less services for them to be able to get out. Compass has not been able to hire a transition specialist, and except for some few bright spots, it's difficult for somebody exiting after they've served their time to re-enter the community. We think that ARPA funds might be useful for that. Arlene, I'm going to let you speak to the 24/7 Mental Health Emergency Center, but in a nutshell, it would be a spot for somebody that doesn't meet the level of the crisis stabilization center. So obviously we've got the emergency department. If something is that severe, below that, I kind of envision the crisis stabilization center when somebody doesn't need the medical piece of it. well, what do we do with all the other cases? What do we do with rumination in the middle of the night? What do we do with all of those situations? So our small group talked about a mental health emergency center that may not be at the risk of maybe hurting themselves or others, but clearly are really needing support, really needing a safe place to be other than the streets, and especially needing connections to services. So the idea behind number 3 there is connection to services. And then the last one under supported and transitional housing, Michael Smith from Lake Whatcom Treatment Center, who runs their co-occurring disorder treatment here in Bellingham. We talked a lot about when people leave treatment options, when people leave maybe serving their time in our jail, it's often very difficult to get housing. And part of that is the cost of housing. Part of that may be anything in a criminal background check that may be difficult. And part of it is you may leave from jail and then you go into a situation of no supports. And this has been an ongoing issue, whether that be what used to be termed halfway houses. Now we use terms more like adult family homes. So those were really service enriched, but also down to the clean and sober type model, where people could have some structure, be able to rent a room safely while they get back on their feet. Joe, would you go ahead and scroll to the next page? Could we go back up to the behavioral health of the first one there? There we go. Okay. So I think this group knows we have Heather joining us. Heather, we're just jumping into the document. Welcome. I tried to frame up a little bit about our discussion, and we just covered very briefly the 4 priority areas. You did such a wonderful job first in getting the members of our group together, but also summarizing this. And I'm wondering if it's not too much to ask, because they've heard me chatting for a while, if you might kind of launch into behavioral health workforce and what type of recommendations we'd like this group to consider.
Sure, sorry to be late. Yeah, let me pull up my document too. So the team really was thinking about, you can see the structure of the document, right? And you saw the high level 4 priorities, and we wanted to explain the problem statement and then some opportunities where dollars could actually be spent. So for this one, we thought about the whole spectrum of employment, with actually offering retention bonuses in addition to hiring bonuses or support for moving. We also talked about that workforce. I just called it a workforce bridge strategy. Could we develop an apprenticeship type program for people interested in the field where they could start working under supervision and have tuition assistance or some other, remove barriers. And then also, we talked about the reimbursement rates really driving salaries, right? Our insurance rates aren't great. And so council could advocate for strategies to increase salaries. We recognize that's probably outside of their purview to just like provide subsidies to salaries. But their voice, working with the healthcare authority or CMS, could advocate to raise those reimbursement rates. And then, because this is solutions for workforce are multi-layered and multi-sector, I think there's an opportunity for council to actually invest in or provide, contract with organizations who are working on those longer term strategies, and make that a priority too. So that was the workforce conversation. And as you all know, that's come up in every single room as a huge pain point right now, that positions are going unfilled. It's not an attractive field for a number of reasons. It leads to a lot of burnout, low pay for high expectations. So that's the workforce piece. Feedback, edits, thoughts?
Councilmember Hammond.
So I think Heather and I may have been separated at birth or something. We think almost identically on some of these things. So the first piece, evaluate the possibility of implementing hiring and retention bonuses. I brought that up 2 weeks ago to the administration. My idea was get a 3-year commitment for behavioral health specialists for the ART. At year 2 or year 3, they get, whatever, 50,000 or whatever the amount is. And that was rejected out of hand. Government doesn't work that way. Government doesn't think like an entrepreneur does. And that's really unfortunate. I think that just, and I'm not criticizing the people that told me that information. I'm criticizing the model that we have, which is it prevents us from moving forward to get to solutions. And the solution is that we need a quality workforce that is well paid, that is incented to apply to jobs and to stay there and to do the work. That's what we need. And so if we perhaps then we contract, we do what other communities do. Eugene, Oregon has an entity called Whitebird Clinic, and they've been doing an alternate response since 1989. And so what if we had a clinic that did the response? They were the employer, not the city or the fire department, and we didn't have to follow these rules that prohibit us from attracting quality workers. And I don't know who the clinic is. I'm not going to name any names because I don't want to provide any expectations. But what if there was a clinic here and we did exactly what Heather says, and we provide them with funding that creates a hiring and retention bonus, or it bridges or it pads the salaries. Now with ARPA, we can only go 3 years, I think. And after that, we'd have to figure something else out. So that's got to be under consideration. But I think coming at it, think like an entrepreneur. I hate the term outside the box, but think outside the box in this case, and really work towards developing those strategies, because this is the linchpin in almost everything we're talking about. It's workforce, and then if you strip that back one layer, it's housing for that workforce. How do they afford to live here? You go to a grocery store, everything's 15% more than it was last year. You go out to eat for lunch, you're not spending less than $20. I mean, it's just, everything's more expensive. You got to pay people what they're, so they can live here. So anyway, I'll stop my soapboxing, but I agree that this is a really good way to frame it and some good strategies to success.
Arlene?
I think one of the things we're talking about is that we need a little bit of boldness in order for things to really happen. And as we keep getting the response, no staff, no applications, and so forth, it stopped everything from movement and from accomplishing what we really want to accomplish. So we have to think of ways to go around that and to encourage people to be the leaders, to be bolder in their thinking, and we're the voice, the nudging voice of encouragement for that. And so those are great ideas. And we're bumping into the same issues. It's housing, jobs, staffing. These are the crucial pieces to all of the social services for them to succeed and be effective. So that's why we keep bumping into them. They're just like, hit your head against it. But yeah, go ahead, Heather. I'm sorry, I'm blabbing away.
No, Arlene, your experience was so critical to forming this document, and you're at so many tables and talk to so many people. So your information is really important. And what I want to say is, Dan, that's so frustrating to hear that kind of response. And in my head, I have the phrase, don't tell me no, tell me how. Mm-hmm. And I don't want to structure a document in terms of what I think government, what their answers are going to be, right? I think you're aligned with me on that. I want to structure it in a way that's like, these are the real requests, and government, if you need to figure out how to allow this in a contract versus paying a stipend directly or whatever the case may be, like, here's the end goal, government, you tell me how it can be achieved through your process. Or if the answer is no, we can't support this, period, end of sentence, good to know. Let's go find someone who can solve it then, because you're not going to be the partner in it, right? And so I'm fine with that.
Under Sheriff Chadwick?
I'd be curious. I don't think it can't be done. Law enforcement has been doing it for years. I actually asked to offer bonuses to get more for our workforce, and I ran into the same thing. And I think it's not that it can't be done, but then you have to do it for every other department and every other area in government. So that may be the hesitation. We have to, if you want to get quality people, you have to be competitive. And right now, Whatcom County, whether it's mental health, law enforcement, any other service, you're competing with King County, Snohomish County, and a lot of those agencies offer bonuses. And maybe part of the problem is they're concerned about like you said, those ARPA funds only last for about 3 years. So, as you're thinking about what you can do with that money, think about things that are a one-time cost. Anytime you add bodies, FTEs, that's ongoing. So after 2 or 3 years, that's like why we don't utilize the COPS grants, because we get money for 2 years and then all of a sudden we have to find some kind of funding or lay those bodies off. But maybe a better way to use that to incentivize it is maybe work with Western Whatcom to stand up their programs that focus on behavioral health and offer scholarships. Maybe a local foundation could offer scholarships for people that are moving into that field, whether it could be mental health conditions. It could also be, there's several pretty big nursing programs. And if you go into nursing with an emphasis in behavioral health, maybe there is funding to help with your education so that you're getting a pool of quality applicants locally that are coming out of those institutions.
Councilmember Hamel?
I'd like that idea. It's a longer term strategy. It's playing the long game on it. But I think that may be a multi factor approach on how to deal with this. The thing that I heard back was that it was labor unions that were representing other groups that might have a problem with this. I think we have 9 collective bargaining units with the city. And that was kind of the rub. And so, why doesn't my group get the bonus for doing the work that our employees, our represented employees do? Now, the thing to me is, I think Heather touched on this, that this is hard work. It's a desperate, I don't want to say desperate. It's a greatly needed component to our response and ongoing treatment. And we're seeing more and more of this. I mean, so in just a little bit here, I'm going to go ride with community paramedic for the afternoon. And I've ridden with law enforcement and fire multiple times. And what I hear from first responders is that behavioral health is a component to many, if not most of their calls. And so if we know that this is an issue, then why don't we just address it? And the way to address it, I think, is financially, in my opinion. I do, Undersheriff, I like the long game approach. I'm wondering how we can retain. I just don't want those students to go through a program that we fund and then they go move somewhere else. And so I'd want to have some kind of mechanism to incent them upon graduation to apply for jobs locally. We have a great shortage. I think the co-chair brought up, maybe it was yesterday, I can't remember, that there was an agency with 100 vacancies that they couldn't fill. I think it was Compass. Things like that. It's just, it's a glaring problem. So, and at the end of the day, money does solve some things. It doesn't solve everything. But in this case, I think it would greatly incent people to take those jobs and keep them.
I think when it comes to either bonuses or paying for their education, a lot of agencies actually have them sign an agreement that they pay it back if they don't fulfill their 3 years, 5-year commitment to the organization. They prorate it and they pay them back. That's happening within law enforcement. I've also seen, I believe it exists within the legal profession. If they'll pay for your law school if you commit to working in public service for so many years. So you see a lot of people come out and they do 3 to 5 years working for a city attorney's office, a prosecutor's office, and then they go into private practice once they've fulfilled that obligation, but they're still in the field, and a lot of them remain local. So that may be an option. I think you could probably structure some kind of agreement that we're going to pay for your education, but the expectation is that you stay here in the community, and whether you work for one of the private providers or you work for a government entity, health department, whatnot, that's an option.
Want to call on Jackie here in a minute. I was just going to add, our community has a couple of wins in this area and some history of addressing like a brain shortage, right, or a skills shortage. And I guess I'm thinking of, SUD program at Wacom Community, RN to BSN. There's a couple of areas that we have, as a community, realized that we have a skills shortage, but we have educational institutions that we can partner with that can maybe help address that. I'd like to call on Jackie.
Yeah, I was going to say that a lot of agencies are already involved in federal programs that where they pay off student loans, et cetera, if the person works for their agency for like 2 years. And I know that's true of CMAR and the other FQHC whose name is totally escaping me.
Unity Care?
Yes, thank you, Unity Care. Kept thinking Interfaith Coalition. I knew it wasn't that. So thank you, Unity Care. And there are some others as well. We have tried many times to increase the wages for, say, our jail workers, because they are on the front lines. What they do mostly is crisis services in the jail. And the agencies, I will say that the unionized shop has been part of the barrier to that. It's interesting to note that they are regional agencies, most of them. Some of them are statewide agencies, like Compass is throughout the region. Lifeline has a couple tentacles in the state. And it's difficult to get the agencies to agree to increase the wages. And somehow it's like you have to address it, not just locally, but on a bigger continuum for those agencies that are regional or statewide. And in some cases, we've been able to get a little higher pay for the jail workers because we required them to be independently licensed, but we weren't able to get like hazard pay or anything like that established for them. So just trying to give you some information is all.
Thanks for that. Anything else on behavioral health workforce and the recommendation that could come from this committee, if you all agree, to the county council about uses of ARPA funds before we move on? All right, Councilmember Hamel, please.
So any recommendations coming out of the committee, remind me, Jill, need to go to the broader task force before they go to the council. Is that correct?
Yes, that's correct.
Okay. Okay, just a process question. Thanks.
Good clarification. So then we would send this to the committee of the whole, or steering first, I guess, in terms of process, Jill?
Not necessarily. You can take it directly to the full task force.
Okay. Seeing no other comments on this particular section here, Heather, I'm wondering if you wouldn't mind taking us through the next section a little bit on the pretrial and reentry support.
Sure. So it's trying to stay connected to the impacts of COVID-19 and connecting ARPA dollars to our priorities. One thing that we've heard about is the delay in processing of people who have cases with the criminal justice system. And one thing that would really support that is the pretrial and reentry support for individuals. And that's something our committee's talked about. And we've also talked about how those are really vulnerable times for people, that if they have strong support, they're less likely to recidivate, more likely to be successful. So some opportunities we talked about were hiring some navigators and case managers that would work with people from arrest to reentry with the mindset of reentry from the very beginning. This is actually, I believe this is an evidence-based practice across, there's different people doing this across the nation, and that is very key to have a mindset of reentry from the very beginning. You make different decisions for those individuals if you're thinking about them being released from jail from the very beginning. We also talked about investing in the staffing and capacity for pretrial and reentry, and then providing trainings and ongoing education in those best practices in trauma-informed care, and in diversity, equity, and inclusion for probation, pretrial, law enforcement, and reentry specialists.
I would just add a teeny bit from Opportunity Council standpoint. Our street outreach team pre-COVID was able to be a little bit more helpful with folks with reentry support. We were doing things like Housing Lab and actually running that in the jail and bringing services to people before they were released. And obviously, I think it makes a ton of sense why within COVID we're not able to do that. Also, the status of our current jail, it's very difficult to bring in additional services for folks to be able to do that. And the team laments that change. There just has not been really successful pathways out for people, nor the staff to be able to help that. And so it's been a real challenge. And Heather, I like the way you frame this, that really kind of pursuant to COVID, which I think is one of the charges from Deputy Executive Schroeder, is be thinking about, behavioral health type positions or initiatives, but secondary to COVID. And I think this is an area that has been really strongly affected by COVID. And thanks for your wording on this, by the way. I think you really, you encapsulated our conversation extremely well in this area. Jackie?
I would just add that I think at least some of these specialists ought to have some behavioral health specialization because so many of the folks have SUD, 80 to 90% have SUD, and a lot of them have mental health issues as well. And I think that is a specialty area. So they should be trained in the very least in how to work with people with behavioral health issues. And I like this idea a lot. And we do have, I don't know how many people know that we do have an open position on the behavioral health team in the jail for a reentry position. So if you know anybody, send them to Compass Health.
Councilmember Hamel?
On item 1 under opportunities, invest in staffing, I would just be cautious on, this goes back to what we were talking about before, creating a bow wave with one-time only funds that go away after 3 years, can't use them after that time. So just having a sustainability plan in place on that one. And then the third item, the navigators, absolutely. I think that's I can't imagine what it's like to try to navigate systems with any kind of substance use disorder or mental health illness coming out of the trauma of being incarcerated. And so I think that investment to me makes sense. But again, we've got to figure out how to sustain the bow wave. And this is my 7th year on council, and I still do not understand how the county balances its budget. I just don't understand how you can not increase taxes and still stay ahead of things. Anyway, that's a separate item, but I would want to make sure that when we're making these investments, I think the county's getting, I forget the number, I think it's like 60 million in 2 tranches. We're getting 10.2 in two payouts. So that's not nothing, but it's got to be sustainable. It's my only caveat.
Arlene?
There was an announcement in the North Sound Behavioral Health Advisory Committee meeting that funding is coming down for navigation, someone who is going to be hiring navigators. So it's beginning, the money is coming. It seems to me that if we want to assure continuity after this, this money, then we need to request that our state legislators, when we have 4 very good state legislators up here in the Northwest who are helping some of this funding come down, we have got to let them know what we're needing in the future. And there's such a powerful force, this group of 4, that I know they'll be able to get things passed. It's pretty exciting that we have this representation at this time.
I would just like to offer, as I heard Dan talking about the bow wave, and how it can be challenging to create a program and then to secure funding on into perpetuity. But one thing that I do think about, and this was more in housing fields, but when we treat people effectively in their communities and in ways that meet their needs, we actually reduce costs in other areas. We may reduce cost to law enforcement. We may reduce cost to burnout to staff that get tired of seeing the same people through the mill, but we reduce costs. So I would offer that sometimes we do need to figure funding on into perpetuity, but sometimes maybe we need to figure out how we can recapture the cost savings that we're generating by doing the right thing. So I would just offer there's a couple of different ways to analyze a funding decision, spending on a navigator, for example. If we are saving in other areas in our criminal justice system, we should be able to recapture that and count that. So I'll stop there. Councilmember Hamel.
I know you guys worked really hard on this and put this together. I think it was yesterday, but one thing I would add to this framing wise is to consider the sequential intercept model for each of these items and tie that model to the pretrial and reentry and where that falls. I think it just makes it stronger.
That's really good feedback. I'm watching Heather writing a note. I think that also really grounds us, as we want that really to be our guiding strategic plan for the task force. Thank you for bringing that up. There wasn't anything else on pretrial and reentry support. Heather, are you game to continue on in the tour to document and talk a little bit about the Mental Health Emergency Center?
Yeah, and I'm really keen to hear too. I mean, I want to make sure that people are okay with the way that things are worded, with the values behind this document, if it's going to be coming from our committee. And so please disagree if you see things in there that you are like, oh, wait, my experience says this is not accurate. So I'll pause if there's anything anyone else wants to add to that section on pretrial and reentry.
I see Councilmember Hamel's hand up.
I've had like 5 cups of coffee, so I apologize in advance here. There's one word that I would take out or change, and it was above all this, and it was the word implore. I don't want to, I think just change. I just don't like that word. I think it's, I think the council really respects the task force and the groups, and I just think we don't need to say it that way. And that's it. I think otherwise the document's great. I think it spells out the needs, but when it comes to making the asks on these items, I think it needs to come from a strength position. I just really think that the task force has done such good work over the years that it really has gained a level of respect amongst legislators. I know that city council absolutely respects the work that's being done. So I would just change that word. That's it.
Do you have another word you prefer, Dan?
Oh, I hate to try to wordsmith on via committee, but just request or I don't think it needs to be like a dire kind of thing. I mean, this is just, to me, these dollars are here. Let's move on them. And we're providing sage advice on how to spend the money in a way that's going to be impactful for our community. So I think we just say request.
Okay.
I would just offer, and Heather, thank you for bringing that back up. The intention to go through this was because we wanted to kind of embody, one, the strategic priorities of the committee, which is all of you, but 2, to give you an opportunity to see this and dig into it. And 3, the last is that offer. If you see something that's either missing or something we should take out, Heather, I hope I'm not overstepping, but that we would agree to kind of dust up after this committee meeting and kind of finalize that and then prepare to send that to the committee of the whole. So I guess the offer is outside of this. We'll make sure that we reach out to behavioral health subcommittee members. And if you have thoughts outside of this or care to share in a different way electronically, that we can do that as well.
Perfect.
All right, so on to our Mental Health Emergency Center.
So many of you have heard our amazing Arlene talk about this vision. And as long as we have one-time opportunity to use some pretty significant dollars, we talked about what are some capital investments that we might want to recommend, even if we know it's dreaming and could be a reach. But one thing that we talked about is this idea of a 24/7 mental health emergency center. And you can see the problem. We share what we're hearing about some of the legislative reforms making a really significant impact on our law enforcement's ability to respond to calls and not having the diversion system really built up yet to adequately divert people who are in crisis or need mental health support. We also hear anecdotally, I do anyway, about where people don't want to go to the ER when they have a mental health concern or if they're feeling suicidal. I hear from parents who don't know where to take their kids, and we hear that the ER can be a little bit of a revolving door, right? We hear that from law enforcement too, that people go in, they sit for 12 hours, they get discharged with a sheet of paper that says call these 30 different places that have wait lists of however long and might not accept your insurance, and good luck. And that just doesn't feel good. That's an anecdote. I don't know for sure all the steps, but nonetheless, the opportunity here is to think about, could we have a 24/7 facility that anyone could access when they are in need with any kind of behavioral health or mental health concern? I highlighted this little sentence about this would be different than the Crisis Stabilization Center in that, and my guess was in our discussion that services would be broader and accessible to anyone in the community. And there is an example, the Crisis Solution Center in Seattle that we linked to. But that's the dream. And Arlene, are there details you would want to add? You're muted.
Arlene, I think you're still muted.
Yeah,
Oh, you're good.
I'm okay now. It's not necessary to invent the wheel. I think there are so many cities that have set up these emergency centers that we can, take some of the modeling in that way. But the main force of concern for me is if we're not going to treat mental problems with police department, we have to have places for people to go besides jail. And most people are not going to be able to go to crisis stabilization because of the requirements that are set up, the standards that are set up. And there's so many people with so many problems, and we want them to get care as fast as possible. So that is the way to do it. I mean, if you think about the way the ER works for medical, it's very immediate. You don't get sent out the door to get an appointment in 3 weeks, usually get immediate care. And we don't have that for mental health there. No, does not happen. People are sent back and forth between the police and the ER. So it's not good care. So this would be a way, this is very preventative. That's one of the best things about it, I think, is preventing situations from escalating and becoming violent or becoming sicker or whatever. I think, it would need to be well staffed and at all times.
Trying to remember who was first. I'm going to take a guess that it was Jackie and then Dan.
Yeah, Arlene, can you say more about, I wasn't aware that the public is not able to access the Crisis Stabilization Center. They should be able to access it. So can you say more about that?
I didn't say that the public is not able to access. What I said is that there are requirements for what kind of client you take, correct? Am I understanding it wrong?
Well, there are screening criteria, sure,
Yeah.
like any place. So if what you're suggesting is a place that just accepts people no matter what their condition or health condition or anything like that, I don't even think DESC would qualify as that. They're a housing placement mostly, and they take people with all kinds of conditions that normally wouldn't be accepted in other housing placements. They aren't really a full service mental health emergency center that I'm aware of. But I think I hear the need, but I'm just not sure that that what's described here is any different from the crisis stabilization center that we've been trying to build the last year or two here. And we focused a lot on law enforcement referrals because law enforcement was very vocal about not feeling like they could access both programs in the facility. So when we built the new facility and added more beds, we had hoped we could iron out some of those issues. But it's not at all intended to be a place where people who have behavioral health issues can't go who aren't involved with the criminal justice system. And we do get referrals from the hospital. We get self-referrals, especially detox gets a ton of self-referrals. So anyway, I guess I question the need for something that looks pretty duplicative to me.
No, I don't think it would be duplicative. I think that a majority of people don't need to stay from 1 to 5 days at because of whatever their crisis is. You're not taking those, you're not treating people with problems that don't need to stay.
I'm not sure I understand what you've just said. Sorry.
Well, you have beds,
Mhm.
right? You're treating people who need to stay.
We're treating people who are in crisis and then trying to find the next level of care that they need and get them to that next level of care. That's the intention.
Right. But if somebody doesn't need to have a 1 to 5 day stay.
You mean if they need less than that? Is that what you're
Yeah.
saying?
Yeah.
No, they don't have to stay the whole 1 to 5 days. Yeah, if they're okay in a 24 hours or 48 hours, they can leave. Yeah.
Jackie, I'm wondering about like the parent and child situation. Could a parent go to the crisis stabilization center if their child was expressing suicidality and be helped there?
Could the parent be helped?
Could the parent bring their kid there?
So that is something we don't have as a youth facility. That's a different thing. And I didn't see that described here, but yeah, a youth facility we don't have.
The idea is not to divide things up into pieces, but to make a center that can receive any kind of problem that is being presented and immediately. And, many of those people would not need to have a stay. Some would.
So in the interest of time, as your co-chair, I want to honor people's commitment, and we're going to quickly run over. I think we could probably do a little wordsmithing and maybe reconvene a little bit about the population definition that such an emergency center might do. I think, Jackie, you brought up some really good points. Maybe we haven't fleshed that out enough to show how it's complementary. It's not meant to be in place of, it's meant to serve folks or be like a drop-in type place for people, but with connection and services and support. But I think we can do a little bit better maybe in wordsmithing that and looking at that. And then Heather, maybe in the shortest amount of time possible, we could talk just very briefly about the last piece, and then we'll open it for public comment. And I do appreciate everybody sticking around for just another minute. We're almost
So
right.
Mike, could I just ask real quickly, is this more like a drop-in center like we had with Rainbow Center? Is that kind of what the thinking is? More like that?
Yes, but expanded significantly. But yes, people could come with any type of need. Some of the differences obviously would be time of day, because Rainbow Center obviously had limited hours. But yeah, the same kind of idea where you could connect into services, but it would be of all ages. Of course, Rainbow Center was only adults. So yes, somewhat similar.
Mike, could I have a comment just briefly? I know you want to move on, but I absolutely love what Arlene's talking about. I've seen it work in other communities. I've toured it, and this is exactly what we need. EMS is not diverting to the crisis center right now. There are a lot of criteria to get in there. They can't do ITAs over there at the moment, and so all those patients are going through the ED. And I have a handful of documented cases where people in the public did go to the stabilization center seeking help, but were turned away at the door to go to the ED. So I absolutely appreciate this thought. I agree we can expand on it, but I totally get it, Arlene, and I agree we need a place like this for diversion of pure mental health people, even if it's 2 hours or 5 days. We need to make that more broadly open.
Okay, I think I'm starting to understand what it is.
Mike Hilly, could I ask you could we connect and you could help me build this description out briefly after this meeting sometime?
Absolutely, Heather. It's been a passion of mine since I got here, and we've been talking about this, so yes.
Awesome.
I would just add for the group that Michael Smith, who runs a treatment center, was also really behind this idea and maybe got the most excited about this and thought this had just amazing potential to connect individuals. He spoke to it very passionately as well.
So I'll do the 30-second version of supported and transitional housing with the invitation to have conversations. Brian, I'm looking at you too, if you want to help flesh this part out. The problem here is that there isn't really a graduated continuum of support for individuals that are not needing the high levels, but don't need nothing. So we talked about opportunities to use ARPA dollars to actually acquire properties designated for reentry support or graduated supports, removing barriers with landlords that wouldn't rent to people with a record. And then there's also a model, the White Feather Reentry in Tacoma, that has a spectrum of programming for and supported housing. So that's the short version of this. And then the last two things, we just wanted to broadly say that we want to add our voice of support for anything that is on the upstream prevention side for youth mental health in particular and families. That's something we all care a lot about. And there's clear COVID impacts. And then the second broad support is for any investment in infrastructure for data and interconnectivity for data systems, as that is a barrier that comes up time and time again about, you know, who's in our jail and why, and how can we make meaning and analysis versus just looking at a booking list of who got booked today.
Heather, thank you so much for the thoughtful coverage. And even though that was 30 seconds, it was amazingly complete. So much appreciated. With that, if there's nothing else, Jill, do we have anybody for public comment?
We have 2 people attending today's meeting. If either of you would like to speak to the committee, please virtually raise your hand now. Yeah, no hands are raised. I would ask, the last item on the agenda is the meeting, increasing the joint meeting schedule with the Legal and Justice Committee, if that's something you guys are still interested in, and if so, that first meeting would be in September.
Co-Chair Hamel, should we do a quick vote on that? I don't know if we still have quorum.
We do have a quorum right now, yes.
Do we need a motion for that?
I don't believe so. If there's just general agreement, we can consider it approval by consent.
Just can we get head nods on that? Okay, looks like we're good.
Thank you. That's everything.
All right. Thank you all. Thank you all for staying late. Thank you all for the thoughts and the input. And Heather, a huge thank you to the LIFT to help kind of capture our thoughts and recommendations to the council of the whole, and agreement here to be able to help wordsmith should you need it. Thanks to all, and until next time.